Hey everybody, welcome to part 8 of our psychiatry review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos. A little bit goes a long way. $1 a month really helps out with paying for equipment and all the stuff that I use to put these videos together. So thank you very much in advance for your consideration. And let's go to question 1. A 24-year-old presents, say it's a 24-year-old man, presents to the clinic with his mother, who is concerned about his increasingly odd behavior. She says, ever since he moved home from college 3 years ago, he doesn't spend any time with his friends and insists on playing video games. He also claims to have special powers to sense others' thoughts. He says he doesn't mind having any close friends and says he likes to spend most of his time alone in his room researching conspiracy theories online because he feels the government is tracking him. He has no significant past medical or psychiatric history. He takes no medications. He's never had a full-time job and dropped out of college due to bad energy from classmates. He doesn't drink alcohol, smoke, or use recreational drugs. He says they're bad energy. He denies any hallucinations or delusions, but says he often feels that people can sense his internal state and that the universe sends him signs through numbers and streetlights. He denies substance use. There's no family history of psychotic disorders. Vitals are within normal limits. Physical exam is unremarkable. Mood is anxious. Affect is constricted. Thought process is tangential. Insight limited. No hallucinations or delusions. Which of the following is the most likely diagnosis in this patient? A. Delusional disorder. B. Schizophrenia. C. Avoidant personality disorder. D. Schizoid personality disorder. Or E. Schizotypal personality disorder. Okay, so let's go ahead and answer this one. This is schizotypal personality disorder, and this is actually a pretty classic case. Now, when we are talking about schizotypal personality disorder, what I want you to associate that with is odd and eccentric beliefs. Okay, now this can get challenging at least in a practice level when you're dealing with diverse patient populations. Okay, we generally know a Catholic, a Muslim, a Jew, a Hindu, maybe a Buddhist, but we don't often know folk religions. And if you ever get a chance to interact with people from developing countries where maybe where they follow folk religions, you might see some of this kind of thinking. And it is very, very important, and you're not going to get tested on this, but it's very, very important that you understand the patient's culture, because with any disorder, it can't be explained by the patient's culture, right? So, if you're talking about, let's say that you've got this person and they light candles because they think the heavens can hear them and grant them their wish. Well, that sounds odd, but if that's part of their culture, their faith, their religion, then it isn't odd. Okay, so there's a cultural aspect, and I just want to point that out for your clinical enrichment. Okay, so what do we have here? Well, odd behavior, that's kind of the giveaway, but he claims to have special powers. He can sense sense others' thoughts, and then he's got this delusion that the government is tracking him. But it's not really taking over his life. He doesn't spend a lot of time on that. And also, the big one here, with schizotypal personality disorder, yes, they have odd beliefs, but they're not fixed. So they're not delusions so much. Okay, he says he feels like the government is tracking him. He feels people can sense his internal state. If you were to ask him, do you know for sure? He would probably tell you no. Whereas if you went to someone with a delusional disorder and asked, do you know for sure? They would tell you, yes, I know for sure. Schizophrenia. Okay, so schizophrenia is, yes, they have delusions, but they also have hallucinations, disorganized speech, disorganized or catatonic behavior, and they have negative symptoms. And it's got to last for more than 6 months, which it would have here, but this patient does not have enough criteria for schizophrenia, and also with schizophrenia, it just ruins your life. Now, this guy, he just came back from college. He withdrew on his own accord, and now he is focusing really on his beliefs, his odd beliefs, and he's doing that from mom's basement. Not a good place to be. Avoidant personality disorder. So these people feel inadequate. They have a severe fear of rejection, and like schizotypal personality disorder and schizoid personality disorder, they tend to be loners. The difference with avoidant personality disorder, they want to have social relationships. The problem is they don't feel good enough. So that's not this patient. Schizoid personality disorder. Okay, so schizoid. Why did I make that I so big? I'll tell you. So schizoid personality disorder, they also are withdrawn. They tend to not prefer to have relationships, but they don't have the paranoid or eccentric thinking. They don't have the magical thinking like this guy's got. Okay, with schizoid, they're really just the happy loners. With schizotypal, they have those kind of what may sound like delusions, but they're not fixed. These sort of false beliefs can't be quantified. It's almost like religion, but because religion is cultural, this is more of like their own religion, right? So it's not schizoid. So schizoid, I made that I big because that's the negative symptoms of schizophrenia. They'll have a lot of that, the withdrawal, but they won't have the hallucinations or delusions. Schizotypal, they tend to have the positive symptoms. So, namely, delusions and stuff like that. Now, both schizotypal and schizoid personality disorder, along with paranoid personality disorder, are part of cluster, do you know? This isn't super important. Cluster A. And those all have a correlation with psychosis. So some of these patients do go on to develop schizophrenia, but most of them don't. Okay? All right, what do we mean, by the way, by affect constricted? You're going to see this in schizoid and schizotypal. So that just means they don't have a very wide range of emotions. Okay, it's not a flat affect. A flat affect is where they basically talk like robots. A constricted affect is, maybe they sound a little sad and then you tell them something good. Oh, yay, okay. They don't really have much variation. As opposed to a labile affect where they're really just sound depressed and you tell them, oh, great, this is awesome. They'll go from extremes. Okay, so constricted is kind of the opposite of that. All right. So here's your schizotypal personality disorder, which we talked about. There are a number of criteria. Ideas of reference, that's different from delusions of reference. With ideas of reference, they think, well, this might be happening. With delusions of reference, this must be happening, and I know it, and nobody can convince me otherwise. So again, here you can see some of the overlap between delusional disorders and even psychotic disorders. Odd beliefs, that's fairly unique to this. Unusual perceptual experiences, I don't feel like this arm is mine. That's not super common, though, in schizotypal. Odd thinking in speech, that's odd thinking, not disorganized. So they may talk to you and they may become very tangential. They may bring up a lot of extraneous things, usually related to their odd behavior. But look out for that. Everything they say should make some degree of sense. Okay, things should follow after another. When you're dealing with somebody with disorganized speech with schizophrenia, they're talking, the words sound right, but it's just kind of all over the place. Odd or eccentric behavior, suspiciousness or paranoid ideation, lack of close friends, and they may have social anxiety. Okay, but that tends to do more with paranoid fears rather than judgment. And you see that in other personality disorders as well. Can't be attributed to physiologic effects of another medical condition, nor to another mental disorder. The treatment here is cognitive behavioral therapy. Now, when you're dealing with personality disorders, most of the time they're egocentric. So these are going to be people who don't want to get therapy. They don't feel they need it. However, if, for instance, they decide they really want to start a family, but they feel like they don't have the social skills, boom, cognitive behavioral therapy. If they're having problems at work, cognitive behavioral therapy. So there are times with these personality disorders where they run into problems, either at work, at home, at school. And so in that case, you need to treat them. So it would be cognitive behavioral therapy. Though that said, a lot of these people are perfectly able to function. They're just a little different. And that's okay. That's okay. All right, question 2. A 15-year-old boy presents to the clinic by his mother due to behavioral problems at school and home. She says, I don't know what to do with him. He's been angry and talking back, which he's done since he was little. But now he's skipping school, lying to people, and he stole $20 out of my purse. This all started when he began high school last year. Last week, he was suspended from school due to a physical confrontation with another student. According to his mother, his teachers have noted that he's disruptive in class, often threatening peers and refusing to follow rules. The patient says, I don't feel bad. Some people get what they've got coming. I hate high school. The teachers are always nagging me and won't let me do what I want. He has no significant past medical or psychiatric history. Patient denies smoking and drug use, but his mom says that she has caught him drinking her vodka and has had to store it away. Patient says, whatever, it's not like I drink as much as you. You set the example for me and Hannah, his sister. And she's going to be the same way. All right. Vitals are within normal limits. Physical exam reveals ecchymosis around the left eye, abrasions on the left arm. Remainder of the exam is unremarkable. Mood is fine. Affect restricted and irritable. Thought process is logical. Insight poor. No hallucinations or delusions. Which of the following is the most likely diagnosis in this patient? A. Oppositional defiant disorder. B. Conduct disorder. C. Antisocial personality disorder. D. Alcohol use disorder. Or E. Adjustment disorder with a disturbance of conduct. Okay. So go ahead and pause. We're going to move on. All right, so this is conduct disorder. Now, in a previous video, we talked about oppositional defiant disorder. Now we're going to talk about conduct disorder. Now, you can see in this vignette, if you're really good at your oppositional defiant versus conduct versus antisocial, you can see that this patient still has some of those attributes of oppositional defiant disorder. And the way I like to explain this to my students, oppositional defiant disorder is the little brat. Conduct disorder is the child or juvenile delinquent, getting into problems with law, getting close to that. And antisocial personality disorder, these are your psychopaths. Okay, they have a hard time with empathy. All right, so what we see here, okay, if you take all this stuff out in the red, you would probably diagnose this patient with oppositional defiant disorder, okay? He doesn't follow rules, he's disruptive, he makes threats, he doesn't feel bad. So that all looks like oppositional defiant disorder. And as a matter of fact, most of these patients do have oppositional defiant disorder. However, the minority go to conduct disorder. Well, this patient is in that minority. Now he's starting to do things that are a little bit more consequential. So he's skipping school. He's lying to people. He's stealing. He was suspended from school and he got into a fight. Okay, this is much more problematic than oppositional defiant disorder. This isn't talking back to your teachers or, pinching the kid next to you or teasing or anything like that. These things, getting into fights, that could be a legal problem when he's 18. Stealing money, ditto. Skipping school, well, what if he skips work? Then he's not going to be able to hold a job. So these are very disruptive. All right, so what about oppositional defiant disorder? We kind of talked about that. They're defiant and irritable, but they're not aggressive. They don't steal. They don't destroy property. Now, sometimes people ask, well, what's stealing? What if I, take a candy out of my mom's purse? Is that stealing? And the answer is no. When it comes to stealing, when it comes to theft, as far as for the DSM, it's got to be of monetary value, and you have to want to keep it. So, for instance, if you took your sister's belt out of her dresser and you want to wear it today, but you plan on giving it back, well, that's rude, but it is not. It's not stealing. On the other hand, if you take your sister's belt and you decide, oh, this Gucci belt, I could hawk it for $500, that is theft. Okay, so know the difference. Antisocial personality disorder. Well, this kid looks like he's on his way to that. But he doesn't have it. Why? You got to be 18. Got to be 18 to diagnose a personality disorder. Alcohol use disorder. Well, he definitely was drinking mom's vodka. I would say more or less that kind of experimentation isn't unusual. I wouldn't diagnose that. The alcohol use is not associated with these things. She caught him, as far as we know, just once. And also, skipping school and lying to people and getting into fights. That might be alcohol related, but then we would expect to see this multiple times. Teachers are really good at figuring out if a kid is drunk, so that is not it. Adjustment disorder with disturbance of conduct. Okay, now remember, with adjustment disorder, you got to have the stressor, and it's got to be 3 months where the symptom develops, within 3 months. Well, he started high school last year. So where did I write that? He started high school last year. Yeah, right there. Okay, so he started high school last year, and this has continued. Well, with the with adjustment disorder, it can't go more than 6 months. Okay? So it's got to be gone by 6 months, and that's not happening here. Okay? If this were 2 months after he started high school and he was behaving like this, we might think adjustment disorder with disturbance of conduct, as long as he doesn't fit the criteria for conduct disorder. That will always supersede adjustment disorder. Adjustment disorder is very low in the hierarchy of mental health disorders. So you have oppositional defiant. This is just here for your own information. Remember, only 30% of ODD patients go on to conduct disorder. Here's conduct disorder. Don't memorize this. Just have a general idea. I mean, you only need to fit 3 of the criteria. So, they're usually going to give you the fights. They might give you bullying. They might give you the physical cruelty. That can be to people or animals. Sexual activity, usually sexual assault. Pyromania. Destruction of property, breaking and entering. I mean, here we're getting into the crimes. You can see how this is much different from ODD. Breaking curfew is something that may be given to you. Repeated school truancy. So you just have an idea of how these kids look. They're the delinquents. They're starting to get in trouble with the law. Okay? Now, if the patient is 18 or older, they can have conduct disorder. However, if they meet the criteria for antisocial personality disorder, that will take precedence over the conduct disorder. But they have to be 18. Can you be over 18 and have conduct disorder? Absolutely, you can. Psychotherapy, family therapy is good. Family therapy is what that family needs, by the way. Mom having the alcohol around, and, we don't know if dad's in the picture, so you look at family therapy and then individual therapy in addition to that. But this is something that needs to be addressed, because approximately 40% of conduct disorder patients go on to develop antisocial personality disorder, and that is a big problem. There are comorbidities with conduct disorder. You're talking about ADHD, mood and anxiety disorders, and substance use disorders. So this mother needs to make sure she's hiding all the alcohol, locking it away. Antisocial personality disorder is very similar to conduct disorder. Specifically here, though, one of the big things is the lack of remorse. Okay, so these people are psychopaths. They do bad things and they don't care. They don't feel bad. Okay, I bet with this kid, if you really sat down and talked to them, this is the point of psychotherapy, he might figure out, yeah, this probably isn't the way to go. Okay, everybody, let's move on to question 3. We got a 32-year-old woman presenting to the clinic complaining of being on edge for the past 9 months. She says, I can't turn off my thoughts. I don't know what it is. I worry about losing my job. I stay up all night wondering if my husband's going to leave me. I get freaked out when my son is at his friend's house because I don't know what he's doing or getting into, even though I know he's a good kid and I know his friend's family. Sometimes I worry that I didn't lock the door at home when I'm at work, and it makes it difficult to concentrate on what I need to do. She works as a paralegal. Despite a good review at her job last week, she reports feeling tense all the time. She has difficulty sleeping, and she says she gets about 6 hours of sleep per night, compensating on the weekend. She has no significant past medical history. She was diagnosed with major depressive disorder when she was 19 and was prescribed escitalopram, but stopped taking the medication after a year and has not had depressive symptoms since. She does not drink alcohol, smoke, or use recreational drugs. Physical exam reveals increased muscle tension and tenderness in the trapezius and cervical paraspinal muscles. Remainder unremarkable. Mood is anxious. Affect congruent and restricted. Thought process is logical, but returns frequently to issues of worry. Insight is good. No hallucinations or delusions. TSH is unremarkable. Which of the following is the best pharmacotherapy for this patient? A. Sertraline. B. Lorazepam. C. Clonazepam. D. Bupropion. E. Aripiprazole. Or F. Trazodone. Okay, so let's go ahead and move on to 4. So this is going to be a follow-up. Appropriate pharmacotherapy is started. 4 months later, the patient returns. She says, I feel a lot better and more relaxed throughout the day. I'm sleeping well and my concentration is better. My mind isn't racing all the time and I feel like I can relax instead of worry so much. Vitals are within normal limits. Physical exam is unremarkable. While you're performing your physical exam, she says, there's one thing though. Ever since I started the medication you gave me, I haven't been interested in sex, and this is upsetting my husband. Which of the following is the best pharmacotherapy to consider in this patient based on the side effect profile? Okay, so a very common conundrum in treating mood disorders and anxiety disorders, because we usually start with SSRIs for both. Okay, let's go ahead and answer 3. This is a patient with generalized anxiety disorder. With generalized anxiety disorder, they have anxiety, but it just controls their life. They're worried about work. They're worried about their kids. They're worried about their health. They're worried about their parents' health. They're worried about their marriage. Okay, now is all anxiety abnormal? No. Let's say your employer just laid off 10 people and we're in a recession and more people may be laid off. You're anxious about losing your job. Totally rational. However, this patient, she's worried about losing her job despite a good review. She is worried that her husband is going to leave her despite there's no evidence for that. She's worried about her kid, even though she knows he's good and he's with a good family. So, I mean, what is there to actually worry about? And that's something you may often hear people say to patients with generalized anxiety disorder, like, why are you worrying about that? Why are you worrying about that? Why are you worrying about that? And the answer is they really don't know. They just can't help themselves. Okay, so another thing that you can see very commonly, as a matter of fact, is muscle tension. So make sure you're doing your physical exam, even though it's a psychiatric patient, especially if you're dealing with generalized anxiety disorder, because increased muscle tension, as we're going to see, is in fact a criterion for generalized anxiety disorder. Now the treatment, SSRI or SNRI, plus cognitive behavioral therapy. Okay, so sertraline, SSRI, lorazepam and clonazepam are benzos. Bupropion, what kind of drug is that? It's an NDRI. Aripiprazole, second generation antipsychotic. And trazodone, I don't know what class of drug that is, but it's for insomnia and can be used also for depression, but not used for generalized anxiety. Okay, so with that said, we know all of these are wrong because we know we go to an SSRI or SNRI. Now, if venlafaxine was an answer, then you might go with that, but I would probably not advise it, and we're going to see why. Okay, now when you are picking an SSRI, because you're always going to go with an SSRI first, unless they have a history of being on SSRIs for other reasons, they had sexual side effects that were intolerable, you're going to start with an SSRI. Okay, what SSRI do you want to use? So I go with fluoxetine. Okay, I go with fluoxetine because sexual side effects are almost the rule rather than the exception. And so with sexual side effects, as far as worst to best, paroxetine has the most, sertraline, which is what we put her on, escitalopram, that's Lexapro, and fluoxetine tends to be the best. Okay, but all of them, all the SSRIs and even some of the SNRIs do have sexual side effects. Okay, now we're going to get to how we can apply that. So the answer here was buspirone. Okay, so buspirone is a second-line agent for generalized anxiety disorder. And it can also be an augment. And we work with some of those same principles that we work with depression. So an SSRI, in this case, or an SNRI, what you do is if you get no response, try different. If you get partial response, augment. And buspirone would be fine to augment. Okay, buspirone in and of itself is not really good for treating severe, but if they have severe and you're giving them an SSRI, you're giving them some kind of other drug like a venlafaxine, then adding the buspar on top of that might get them over. And I do believe, I've read some things that giving buspar as an adjunct helps with the sexual side effects, but I'm getting mixed. When I read the literature, I'm getting mixed signals, but that's something interesting. Now, if you try a second SSRI or SNRI, then it's time to go for something else, like buspirone. Okay? So the major problem here was the side effects, the decreased libido. In men, you can experience that as a erectile dysfunction or delayed orgasm. Now, in patients who are having depression, I would go for bupropion rather than buspirone. Buspirone is, again, it's one of those drugs that's really good to augment, okay? But the reason I would use Wellbutrin or bupropion is because it does not have the same degree of sexual side effects. Okay, bupropion is an NDRI and has very little, if any, sexual adverse effects. Who can't get bupropion? What people is it contraindicated in? Seizure disorder. Now that doesn't mean if they had febrile seizures when they were a baby. We're talking about people with epilepsy. Okay, contraindicated, absolutely contraindicated in seizure disorder. So you have generalized anxiety disorder, excessive anxiety and worry. It's in a number of domains of their life. It's got to be at least 6 months. Most of these people are way beyond that. They'll tell you it's been going on for years and years. It's got to be a number of events. Can't just be one thing. Okay, restlessness or feeling on edge. That was this patient. Fatigue, yes. Concentrating, yes. Irritability, we didn't really see that. Muscle tension, yes. Sleep disturbance, yes. She had 5. She's got generalized anxiety disorder. Okay. Now, you can see a lot of this just relates to difficulty sleeping. If you're anxious, if you're thinking things, you're ruminating, it's going to make it difficult to sleep. And if it's difficult, you've got the sleep disturbance, if difficult to sleep, you're probably going to be more fatigued. You're probably going to have difficulty concentrating. And so all right there, you got 3. So at that point, it's very important that you know this is excessive anxiety and worry, and it's got to be in a number of activities and environments. First line, SSRI or SNRI and cognitive behavioral therapy. That's very important, both of them. We want to do behavioral therapy and medical therapy. The two together are more effective than one alone. Second line, buspirone or benzodiazepines. I would steer clear of benzodiazepines, but if you are asked what benzodiazepine to give, I almost put Klonopin. Clonazepam. Okay, clonazepam or Klonopin, same thing. Okay, 5.7% lifetime prevalence of generalized anxiety disorder. That means like 1 every 19 people will have GAD at some point in their lives. Very significant comorbidities with generalized anxiety disorder. A lot of these people, I didn't put it on here. Some of these people will use substances like cannabis or alcohol, so they could have a substance use disorder. And they do that to self-medicate. Major depressive disorder, other anxiety disorders. Some of these people could have specific phobias, fear of flying, fear of speaking. OCD, you can imagine with generalized anxiety disorder, you get really anxious about something and you might have a compulsion to go check to relieve that anxiety. That's when you cross into OCD. But this isn't OCD. We did see that she gets worried, she locks her door, but we didn't see that she has to go back to make sure it's locked. And then there are some medical conditions that are associated with anxiety. I'm sure you've heard IBS and fibromyalgia. With these disorders, very important to treat the comorbid psychiatric condition. We don't really have good therapy for IBS. We don't really have good therapy for fibromyalgia. However, if you treat comorbid psychiatric conditions, often it'll help their physical symptoms. So, that can be pretty nifty. And that's why these patients with IBS, with fibromyalgia, they get sent off to psychiatrists. And they're like, oh, the doctor thinks it's all in my head. No, the doctor thinks your head is contributing to it. And we are going to fix your brain biochemistry and help relieve your symptoms because that is shown to work. Okay, so be very careful when you're explaining why you're doing this to your patients because you don't want them thinking you're just sending them to a shrink. You want them to know that psychiatric care is part of the treatment for IBS. It's part of the treatment for fibromyalgia. Okay? Question 5. Okay. A 28-year-old woman presents to the clinic with her mother who is concerned about her persistent belief that Justin Bieber, whom she has never met, is secretly in love with her. This started when she attended a concert last year and she believed he was looking at her while performing, indicating romantic interest. Over the past 6 months, she's become increasingly withdrawn socially, staying up all night listening to his music and commenting on his posts on Instagram. She says, I'm never tired because I'm in love. Her mom says, she just spent $1,000 on front row tickets because she's convinced he'll notice her. She denies hearing voices and seeing things, but admits to feeling anxious and having trouble sleeping. She has no significant past medical or psychiatric history. She works as a preschool teacher. She doesn't drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. Physical exam is unremarkable. Mood is fine. Affect is congruent. Thought process is logical, but returns frequently to issues of worry. Insight is poor. She insists that Biebs is reading her comments and is communicating with her through coded messages on Instagram. When her mom challenges her about this, the patient becomes angry. Which of the following is the most likely diagnosis in this patient? A, bipolar 2 disorder, B, delusional disorder, C, schizophrenia, D, schizotypal personality disorder, or E, narcissistic personality disorder. Okay. I probably should have cut out this. I think I copied that from my last question. So I apologize for that. Okay. Although she could be a worrywart, who knows? She certainly doesn't have generalized anxiety. All right, let's go ahead and answer this one. So this is delusional disorder. Now, with delusional disorder, what you're going to find is unlike the personality disorders, these, certainly unlike schizophrenia, these patients are going to be fixated on one thing. And unlike our schizotypal personality patient, these people who have these one delusions, you cannot talk them out of it. And if you try, they may get angry. And by the way, an ethics question, patient care question, what do you do when you've got a delusional or psychotic patient? Do you tell them, no, that's not right, let me explain to you what's actually going on? No. Keep your distance. Don't challenge the delusions. That gets tested. Okay, so what about bipolar 2? Does she have mania? Well, she has some mania symptoms, but they all relate to the delusion. Okay, so what we see is perhaps a grandiose delusion that this millionaire is in love with her. She's not sleeping. She spent $1,000. She gets angry. That could be, like an irritability, I guess. So, but she doesn't have any other symptoms, and this has been going on for many, many months. With mania, we're talking, a week at the most, really, for most people. Okay? So, we don't have any of, we don't have enough symptoms for mania. So that's out. Schizophrenia, nothing bizarre here. These are delusions. They could theoretically be possible. Wouldn't say that to the patient, by the way. But it could happen. We're not talking about aliens implanting computer chips into you. We're talking about, that could happen. It could happen. It's not, but it could happen. Okay, so not schizophrenia. Schizotypal personality disorder, we already talked about that. Okay, she's not having magical thinking. She's fixated on the beebs. And narcissistic personality disorder, well, this is kind of a grandiose delusion. Erotomanic and grandiose kind of have a little bit of overlap. I mean, she thinks that this big pop star is into her. You can see how that can be grandiose. But this is erotomanic. So this is not narcissistic personality disorder. We don't see any of the other criteria, like a need to feel special, feeling better than other people, and stuff kind of along those lines. So that is out. And it is delusional disorder. So let's talk about delusional disorder. It's the presence of one or more delusions for at least a month. There are no prominent hallucinations, and if there are, they're related to the delusion. So she may wake up feeling the beebs caressing her shoulder, or maybe she hears his voice. But there's always going to be good insight into that, okay, because they're not psychotic. Apart from the delusion ramifications, functioning is not markedly impaired. They can kind of turn this off and on. Okay, whereas with personality disorders, not so much. Psychotic disorders, absolutely they can't. Okay, so they can generally get through life, and you can see she is a preschool teacher. So I think that this one was a preschool teacher, right? Anyway, yeah. So she's doing fine. She's just got this delusion. Her mom is really worried about it. Can't be due to a medical disorder. Can't be due to another mental disorder. This is fairly low on the hierarchy. And it can't be due to a substance or a medication. Important differentials. We talked about all these. Now, with some of these personality disorders, you can start to get a little bit of overlap. So what I'm going to do is I'm going to tell you some of the different types of delusional disorders. So the first one is the one we already talked about. That's erotomanic. Okay? Erotomanic. And this can be associated with borderline personality disorder or histrionic personality disorder. Okay? What's the next one? Grandiose. Okay? And what do we call a delusion that's grandiose? Delusions of grandiosity. That's G. That's G for our mania. So that could count towards mania, but you're going to know from the outset the difference. Okay, so this could be bipolar affective disorder. We use BPAD so we don't confuse it with borderline personality. That's something I was taught long ago. Persecutory delusional disorder. So what's that? Persecutory is where the delusion surrounds being conspired against, being cheated on, spied on, followed, poisoned, but it's not all of those things. It's one or two maybe of those things. So maybe they're absolutely convinced their wife is cheating on them, and so the husband goes and he breaks into the wife's phone, checks her Facebook, checks her Instagram, he's putting a tracking device on her car. You can see very, very, very problematic things, and it's a paranoid delusion. Now, persecutory can look like paranoid personality disorder. However, with paranoid personality disorder, this is going to start fairly early on in life, young adulthood, maybe even adolescence, even though we can't diagnose it at that point. But That's going to go through multiple domains of their life. They're afraid their boss has it out for them. Their friends don't want to be friends with them anymore, and they're talking about him behind their back. The wife is cheating. It's just constant. They're always paranoid. With delusional disorder, it usually focuses on one thing. So you can kind of think of it as analogous to generalized anxiety disorder to specific phobia, right? A lot of things versus one thing. And then I don't think I told you. Okay, then there's somatic. This one isn't super common, but this is where it surrounds a bodily function or sensation. This gets really close to obsessive compulsive disorder. These people might be constantly under the impression that their hands are dirty. So you can see how that can kind of go there. But there's got to be a delusion. Okay, not just my hands are dirty, but like I've got bugs inside my hands, or I've got bugs on my hands, or something like that. I'm going to get really, really sick if I don't wash my hands. There's a delusion. Again, it gets really difficult to tease these apart. The grandiose delusions, I'm not sure if I mentioned what that is, but that's where you have you think you have this great skill or talent and made some important discovery, but it hasn't been recognized yet, and you're convinced. That, again, is something that you can see in bipolar disorder, but they're going to lack all the other stuff. The treatment here for delusional disorder is antipsychotics. It does work. And cognitive behavioral therapy is good in addition to that. We don't want them on antipsychotics for the rest of their life. Okay, question 6. A 27-year-old woman presents to the clinic complaining of persistent feelings that she is, quote, not real, and that the world around her feels like a movie. She says these sensations have occurred daily for the past 6 months and last for hours at a time. She continues, sometimes it feels like I'm watching my life from outside my body. I feel like I'm going crazy. She denies auditory or visual hallucinations, delusions, or suicidal thoughts. She reports increased anxiety, but no panic attacks or depression. No significant past medical history, notably negative for seizures and traumatic brain injury. She was diagnosed with generalized anxiety disorder in college and was prescribed an SSRI, but went off it after 3 years. She doesn't drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. Physical exam is unremarkable. Mood is anxious. Affect is congruent to that. Thought process is logical. Insight is good. Urine drug screen is negative. Which of the following is the most likely diagnosis in this patient? A, panic disorder with dissociative symptoms. B, depersonalization, derealization disorder. C, generalized anxiety disorder. D, post-traumatic stress disorder. Or E, complex partial seizures. Okay, let's go ahead and answer this one. So this is depersonalization, derealization disorder. And what I want you to know right off the bat is that this is an ego-dystonic condition, as you can already see from this vignette. That means the patient has insight. They know that something's off. It's not like a personality disorder where they deny they have a problem. It's not like active mania where they think they're fine. This is a patient who's going to come in and say, Doc, I've got these symptoms. It feels like things around me aren't real. It feels like I'm not real, but I know I am. Okay, that's an ego-dystonic, good insight condition, and that is very key for depersonalization, derealization disorder. So here we see depersonalization, here we see derealization, and here we see depersonalization. What's the difference? So depersonalization is this unsettling sense that your body, yourself, is not your own. It's like you're observing your thoughts and actions and your own body from the outside, like a stranger could. Derealization, on the other hand, is about the external world. It's where the environment itself is perceived as strange or dreamlike or unreal. Some will describe it like this patient, like they're watching their life in a movie or in a TV. All right, so important, there is a comorbidity with anxiety disorder, and as we saw in this patient, this provoked her anxiety. That is not a surprise. You can imagine if you had these sorts of symptoms, it would be very anxiety provoking. And what we do see is that in many cases, the real problem, and the problem that we can often treat, is the comorbidities. Okay, there is no pharmacotherapy for depersonalization, derealization disorder. So what we do is we send them to cognitive behavioral therapy, and then we determine whether there are comorbidities. Okay, now this is super important. The insight is good. We kind of talked about that here. But there's something called reality testing. These patients know that what they're experiencing is not normal. They know the world is real, but it doesn't feel real, okay? So it's really an odd condition. Now, I want to draw your attention to here is E, complex partial seizures. This, depersonalization and or derealization, can be an aura symptom of temporal lobe epilepsy, which can then be succeeded by a full-on grand mal seizure. All right? But this is not it. We don't see anything about seizures. Okay, she hasn't had any kind of generalized seizure. We have no evidence of that. Panic disorder with dissociative symptoms. You can get these kinds of symptoms in association with a panic attack, but we don't see any panic attack in this patient's history. Generalized anxiety disorder. How about that one? This sounds like an anxious patient, but is this generalized anxiety? No. There's nothing across other domains. She's not anxious about her bills. She's not anxious about losing her job. She's not anxious about her kids going to school on their own. That's the sort of thing you see in generalized anxiety. Post-traumatic stress disorder, that requires exposure to trauma. There's avoidance, there's hyperarousal, there's poor mood. We don't see anything like that here. So the answer is B. So here are the criteria here. We talked about all of these things individually. You can look at this, get the general sense. Don't memorize the DSM. Just get the general sense of each of these disorders, what separates them apart from the others, and you'll be good to go. First line management, cognitive behavioral therapy. You may add an SSRI. Many of these patients will have comorbid mood or anxiety disorders. Now, I just put down here to note that this may come from early childhood trauma or anxiety. There are higher prevalence rates seen in various other psychiatric disorders, and no fixed duration is needed for diagnosis. Okay, question 7. A 42-year-old woman presents to the ED with her partner due to confusion, agitation, and involuntary muscle jerks that started this morning. Over the past 2 days, she's also complained of vivid nightmares, dizziness, nausea, and a buzzing sensation in my head, quote. She has no history of seizures or substance use. She has a past medical history of fibromyalgia and a past psychiatric history of major depressive disorder and chronic insomnia. She had been managed, but with duloxetine and low-dose trazodone at bedtime. However, due to refill delay after losing her job and insurance, she abruptly stopped all medications. She doesn't smoke, use alcohol, or use recreational drugs. Vitals show blood pressure 136/82. The remainder are within normal limits. Physical exam is notable for occasional myoclonic jerks of the upper extremities, exaggerated startle reflex or response, and mild hyperreflexia. No clonus, rigidity, or autonomic instability is noted. Mood is, quote, anxious and overwhelmed. The affect is congruent to that. Thought process is logical with mild distractibility. Insight is good. CBC, CMP, and urine drug screen are all within normal limits. CT of the head is unremarkable. EEG shows no epileptiform activity. Based on the most likely diagnosis, which of the following is the best next step in the management of this patient? A, olanzapine. B, clonazepam. C, restart duloxetine at prior dose and taper down. D, fluoxetine. Or E, reassurance, no pharmacologic intervention needed at this time. Okay, let's go on to the answer. So what we have here is a patient with antidepressant discontinuation syndrome, which happens when you abruptly stop short half-life antidepressants. Okay, those are going to be particularly things like paroxetine, duloxetine, and venlafaxine. Those are the most common agents that are implicated in this. And the reason is because they have very short half-lives. So anything with a short half-life is going to cause more withdrawal symptoms, right? So you're going to, if you're on Klonopin, for instance, clonazepam right there, you can see it. That has a much longer half-life than something like Xanax, alprazolam. And so you know which one is more likely to cause withdrawal symptoms if you're taking it frequently. Okay, you're much more likely to get addicted to Xanax than you are to get addicted to Klonopin. And it's kind of the same thing here, except we're not really talking about a psychological addiction. We're talking about a physiologic dependence, if you will, which then causes withdrawal symptoms. And so naturally, the short half-life agents, paroxetine, duloxetine, and venlafaxine, are going to be the common culprits here. What do we see symptomatically? Well, you can see this here. The sensory disturbances, also called brain zaps. That's not a technical term, but patients will often describe it that way. Especially if you say, do you ever feel like you got brain zaps? And patients will say, yeah, that sounds familiar. But there are a number of symptoms, and often this is confused with serotonin syndrome. Now, unlike serotonin syndrome, you're not going to have clonus, you're not going to have autonomic hyperactivity or instability. Serotonin syndrome has that triad of mental status changes, autonomic dysregulation, and neuromuscular hyperactivity. You don't see that in patients who have antidepressant discontinuation syndrome. You also look at the history, right? The history will help you there. Serotonin syndrome is an overdose. Antidepressant discontinuation syndrome is a withdrawal. All right, let's run through here. Olanzapine. No, patient's not psychotic. Clonazepam. That could help with anxiety, but not the underlying cause. What about fluoxetine? So, I'm going to say this. Fluoxetine can be given when you restart the medication. So let's say you restart duloxetine and the patient is still having symptoms. What you can do is add on to that fluoxetine. And we never give 2 SSRIs, but this can abate some of the symptoms while they're waiting. Do not do this unless you are a psychiatrist, okay? That's never the right answer on your exam. I'm just telling you as a matter of general practice that this can be done, okay? But know this, for ADS, the treatment is to restart the same medication that they were on, okay? That's what we do. So it's not fluoxetine. And then reassurance, no, we have to restart the medication. This is not a deadly disorder. All right, this is an inconvenience, but it is something that we can treat. Okay, question 8. A 67-year-old man presents to the clinic with his daughter who is concerned about recent behavioral changes. Over the past several months, the patient has become increasingly secretive and has started making frequent trips to a nearby casino. He's also been observed engaging in compulsive online shopping, often purchasing items he doesn't need. The patient admits that he gets a thrill from these activities and feels anxious when he tries to stop. He has a past medical history of Parkinson's disease and a psychiatric history significant for major depressive disorder. Medications include carbidopa-levodopa, pramipexole, and sertraline. Vitals are within normal limits. Physical exam reveals a mild resting tremor and bradykinesia, otherwise unremarkable. He denies hallucinations, delusions, or mood symptoms. His cognition is intact on screening. He has no history of manic episodes or substance use. Which of the following is the best next step in the management of this patient? A, discontinue carbidopa-levodopa. B, decrease dosage of carbidopa-levodopa. C, discontinue or decrease dosage of pramipexole. D, discontinue pramipexole and start ropinirole. E, discontinue sertraline and start valproate. Or F, add aripiprazole. All right. So I'll give you a chance to pause here if you wish. And we will go ahead and answer this one. So the answer is to discontinue or decrease the dosage of pramipexole. When we have a patient who has Parkinson's and is on dopaminergic drugs, we always run the risk of flooding the mesolimbic and mesocortical circuits, which are the very pathways of pleasure, reward, and drive. And that is going to cause these compulsions. Now remember, we use dopamine agonists in Parkinson's to stimulate the nigrostriatal pathway, but we have multiple dopaminergic pathways in our brain. Okay, we also have the tubuloinfundibular pathway. And so you can get, particularly in women, you can get galactorrhea. But the more likely thing you're going to run into, especially on your exam, is going to be these more dramatic compulsive symptoms that are associated with dopaminergic agonists. What we don't want to do in these patients is to stop carbidopa-levodopa. Because if we do that, their motor symptoms are going to come back. Carbidopa levodopa is the cornerstone of Parkinson management. If you put a patient on that, you're not going to stop it. Okay, so that is wrong. Same with decreasing the dosage. We're going to leave that be. Discontinue pramipexole and start ropinirole. Yeah, you're just here stopping one poison and starting another, so that's not going to help. Discontinue sertraline and start valproate. How about that? Why not? Valproate is for bipolar disorder, for mania. It's not going to help. This patient is not manic. Okay, they know that there's a problem. He feels anxious. He wants to stop. In mania, they're fine. They don't want to stop. They want to go to the store and buy $5,000 worth of clothes and head on down to Miami and have sexual escapades. I mean, I'm exaggerating a little bit, but you do see this. Okay. And then how about add aripiprazole? No evidence of psychosis. However, people with Parkinson's disease can develop psychosis, in which case aripiprazole would be fine. All right, question 9. A 35-year-old woman presents to the clinic complaining of mild diffuse abdominal pain for the past 2 years. She says that she also has had chest pain on and off during this time and often feels tired despite getting 7 to 8 hours of sleep every night. She says, I just know something's wrong, but every time I go to the doctor, they do blood work and tell me to see a therapist, which I'm already doing. It's frustrating, and I'm starting to have a hard time sleeping because I worry that I might have something serious. She has no significant past medical history. Psychiatric history includes generalized anxiety disorder, which is controlled with psychotherapy. She does not take any medications, but uses multiple over-the-counter supplements, including a multivitamin, ginseng, ginger root, and melatonin. She's kept a detailed diary of her symptoms over the past year. She has never been pregnant, and her menstrual cycles are 28 days and regular. She does not drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. Physical exam reveals mild diffuse abdominal tenderness to palpation. No rebound or guarding. Remainder of the exam is unremarkable. She denies mood symptoms. Upon review of her previous provider notes, you see that 3 months ago she was seen in the clinic for a similar complaint. CBC, BMP, TSH, EKG, chest x-ray, cardiac enzymes, and polysomnography were all unremarkable. Which of the following is the most likely diagnosis in this patient? A, illness anxiety disorder, B, conversion disorder, C, generalized anxiety disorder, D, somatic symptom disorder, E, factitious disorder, or F, malingering. Okay, now, I want you to lock in your answer because question 10 is going to be a follow-up on this. All right, you can pause here if you want. Okay. Which of the following is the most appropriate statement to make to the patient at this time? And I'm just going to let you read this. I'm not going to read through all these. It just takes a bunch of time. Okay, go ahead and pause here if you want, and we're going to move on to the answer for question 9. So this is somatic symptom disorder. Somatic symptom disorder requires you to have one somatic symptom, belly pain, something like that, for at least 6 months. These patients are preoccupied. They're worried. They're anxious because they feel like they might have something. And I say feel, okay? This helps you distinguish from illness anxiety disorder. In illness anxiety disorder, they are preoccupied that they might have an illness, even though they don't have any symptoms. Okay, so that would be like my mom when she was in her 30s. I remember when I was a little kid, 20s really, constantly worried that she had cancer of some sort. It was just all the time with her. Unfortunately, in 2021, she did develop breast cancer, but, that can happen to anyone. But that is illness anxiety disorder. You're preoccupied, usually with a specific illness, despite no symptoms. It sounds a lot like somatic symptom disorder, but the difference is somatic symptom disorder, they actually appreciate symptoms. Okay, they feel symptoms. Okay, whether that be belly pain or headache or burning sensation in their leg, you name it. It can be anything. Okay, so not illness anxiety. Conversion disorder, what's that? So conversion disorder has to be neurologic symptoms, and this patient has belly pain, so that cuts it off right away. And she also has chest pain too. So what we're not seeing here are neurologic symptoms. We're not seeing motor symptoms. We're not seeing paralysis or blindness or psychogenic non-epileptic seizures. This is always neurologic. Now, this is really important. These patients have what we know as label indifference. It's a French word, beautiful indifference. So these patients, they have conversion disorder, right? They don't care. They're fine not being able to move half their body. They're fine not being able to see. They're fine with their psychogenic seizures. They'll be laying in their room like, yeah, it's okay. I don't really know why I'm here. I can't see anything, but that's where you know you're dealing with conversion disorder. And a lot of times these patients are confused with malingering or factitious disorder because they aren't concerned about their symptoms. Don't judge the patient, okay? With a conversion disorder, you can be indifferent to your symptoms. That's a very common manifestation. Another thing that you'll see is a symptom clinical mismatch. So you've got a patient who says they can't see, yet you look in their eyes, there's no cataracts, there's fine pupillary reflex, extraocular motions are intact. You look at their retina, you can see on through the ophthalmoscope that there's nothing wrong. Okay, yet they're blind. What's going on? That is, when you see that, you should think of a possible conversion disorder. Generalized anxiety disorder, like we talked about, that's patients who worry across domains. These are patients who worry about their finances. They worry about losing their job. They worry about their kids going to school. They worry about possibly getting a disease. They worry about all sorts of things. Okay, multiple domains. Factitious disorder, what's that? That's where symptoms are intentionally produced to assume a sick role. Okay, so unlike conversion disorder and unlike somatic symptom disorder, these patients know their symptoms aren't real. They know that they're doing this to themselves, but they aren't doing it for cash. They aren't doing it for gain. They're doing it to assume a sick role. Do you know what we used to call this? If you're old like me, which is not very old, you probably remember this term, Munchausen, same thing, okay? And commonly on the USMLE, they'll give you this patient as a healthcare professional. For some reason, the USMLE likes to conflate factitious disorder with people who are in healthcare. Presumably because there is an increased rate among healthcare professionals. I've never read that, but I'm assuming that's true because that's what the USMLE likes to do. And then malingering, this is similar to factitious disorder, except you're not wanting to assume the sick role. You're trying to get secondary gain. You're trying to get a letter to get off work. You're trying to get disability, things like that. Okay, now question 10 really just comes down to the treatment. It doesn't really matter what you say. The treatment is in here. Regular visits, okay, with one physician. So we don't want these patients going and having visits with multiple physicians and you got too many cooks in the kitchen. What you want is for the patient to have regular visits every 3 to 6 months, maybe. You set it up. You figure out with the patient. Regular visits. Okay, this gets asked. This is high yield. Okay, so when you're dealing with somatic symptom disorder, it is regular visits. I can't stress that enough because it comes up. It came up on my test. I remember it clearly. Okay, so if you look at all these other ones, they're very dismissive. You're not suffering from any medical condition at this time. True, but she is suffering from a psychiatric condition. Would you like to try a medicine that could help with your anxiety? She doesn't have an anxiety disorder. Okay, she does have anxiety, but she doesn't meet the criteria for generalized anxiety disorder. I understand you're concerned about your symptoms, but there's nothing we can do. Yes, there is. Regular visits. You are experiencing somatic symptom disorder. True. I would like to refer you to a specialist who helps patients like you. No, because again, regular visits is the treatment. Okay? You're not going to send these patients off to a psychiatrist. They're going to send them right back to you and say they need regular visits with you. Your symptoms don't fit with any medical condition. Would you be comfortable with a referral to a specialist? Again, that's you not doing your job. So the answer is E. Here's your somatic symptom and related disorders. There are multiple. We saw these in our wrong answer choices. Remember, illness anxiety disorder, that's where you fear having a serious illness despite having no symptoms. Somatic symptom disorder is where you feel like you have symptoms and there's anxiety and preoccupation surrounding it. We think it's possible that somatic symptom disorder may be a neurologic imbalance, may have to do with parts of the brain, including the thalamus or parts of the cortex, but we don't know. But that's where the speculation is at. Conversion disorder is always neurologic. It's where the symptoms and the physical and the clinical exam are mismatched. Remember the label indifference that comes up on the exam. These patients they're not anxious. It's almost like the opposite of somatic symptom disorder. Right? Somatic symptom disorder, they are very distressed. Conversion disorder, not so much. Remember that conversion disorder has to be neurologic symptoms. Somatic symptom disorder can be neurologic too. But again, remember, the difference between somatic and conversion is the patient's attitude towards it. Factitious disorder and malingering, we talked about. We're not going to go over those again. So here you have somatic symptom disorder. Again, DSM-5 criteria. You don't need to memorize this. Just have a general idea of what you're looking at. In the management, regularly scheduled visits with the same provider. Make sure and legitimize their symptoms. Affirm them. Tell them what you are experiencing is real, but it is a mental health condition. And so what we need is to have regularly scheduled visits and potentially cognitive behavioral therapy. Focus on stress reduction, improve coping strategies, send them to a therapist. That can help. Limit unnecessary workup and specialist referrals, common sense,
and a mental health referral if the patient will accept.